With that, I invite all our panelists. So we'll start with quick introduction. My name is Mohsen, and I lead venture at Fortis Biotech.
Hi, good afternoon. Good afternoon, everybody. Sorry you could not take a break, so we're going to be stuck with us for the next, 40 minutes?
Yes.
Okay, all right. My name is Murali Gopalakrishnan. I lead a group in business development at Teva Pharmaceuticals on search and evaluation, looking at opportunities broadly in neuroscience and other areas. I took this role at Teva, very, very recently, but before that, I did a similar role at AbbVie, which is also another pharmaceutical company, and they're located in Chicago, where I was also leading the search and evaluation to really look at opportunities from everywhere in the world that we can collaborate with and augment, what the pharma pipeline can be built. So that was my role, and it's a great pleasure to be here.
Hi, Gowan. Thank you. Hi, my name is Bill McKeon. I work here at the Texas Medical Center, so it's great to see TMC3 building thriving. I call it Thunderdome, if anyone remembers Mad Max Thunderdome, when seeing all 4 floors lit up with some tremendous minds here around brain. We designed this building and this campus for translational research. Often industry had to come into many of our 60 institutions to find what was happening in neuro, what was happening in oncology and such. And we really felt if we could design an entire campus for really translational research and venture capital. On our top floor, we have the TMC Venture Fund, which I might mention. And we like to invest early stage technology. So delighted to see a lot of the things that are coming here, and welcome.
Hi, everyone. So Luisa Salter-Sid. I am an immunologist by training. So full disclosure, the neurology thing I'm learning as well. I was many years at Bristol Myers Squibb, where my last job I led immunology, immuno-oncology, and genomics discovery. Was 5 years of Flagship as CSO. And now for the last 2 months, I've been at Osage University Partners, so a good title. And one of the things we are trying to do there is really to launch a fund called Lattice Fund to invest in companies out of academia. And so centers like these and opportunities to really be interacting with many of you has been a great opportunity to help us shepherd this fund. So thank you.
Hi, everybody. My name is Giulio Taglialatela. I'm Vice President for Brain Health at UTMB and the Director of the Moody Brain Health Institute. And I've been studying the neurobiology of Alzheimer's disease for as long as I can remember. No pun intended, of course. And more specifically, I've been interested for many years in cognitive resilience. Individuals with profuse Alzheimer-like pathology that, however, remain cognitively intact. And that's my personal area of concentration. And I'm glad to be here, and I thank for the organizer for giving me this opportunity.
Right. Thank you very much. So Houston has built a giant biotech ecosystem, with TMC being the largest medical complex in the world, with over 10 million patient encounters per year. And through all these sessions that we had yesterday and today, we have established, showcasing the amazing infrastructure that this is the place to build companies. Houston is the place to build biotech companies and really industrialize the brain therapeutics. And also it is in Houston's DNA to solve complex problems. So where else brain science would go other than call upon Houston, we have a problem. And Houston has taken that head on with UTMB, TMC, and the partners leading charge in industrializing the brain therapeutics and brain science as a field. So this session will touch upon a few things: how we do industrialization of brain therapeutics, scaling illusions, like the things we need to know, because building companies in CNS is way different than any other therapeutic areas. We'll talk about how to have a brain science-specific playbook, similar to how in oncology we have been building companies after companies. And then what are the changes we need to make, including in investment models, to allow for all of this to happen. So with that, let's start with the scaling illusions. So brain science is full of breakthroughs that dazzle on a slide, but quietly fall apart when they reach much more stringent regulatory stage, larger clinical studies, or at the payer's desk. So Murli, you have spent significant time across different therapeutic areas and has been running big CNS portfolios at AbbVie and now at Teva. What looks scalable at early development routinely break at more stringent development at commercial scale up, among others?
Yeah, that's a good question. Thank you for the question. So, just to maybe I'll start with, it's a great time to be back in CNS research. I mean, I would not have said this, 10, 12 years ago, but if you generally look at this space, a lot of pharma companies are coming back to CNS, right? Companies have made significant commitments, especially those of them who walked away, 12, 15 years ago. They're all coming back to neuroscience, seeing the potential of it. So that's exciting part of it, right? So, but coming back to your question around scaling is not that easy, right? Certainly in neuroscience, and I know Hussein Imanji walked through some of the challenges, but at the fundamental level, we still are in a place where we are building, we are sort of flying the plane while we are building it at the same time. We're still trying to understand the disease biology, the pathophysiology, and how do we target. I think that's an important piece of it. So we're still learning that. We're still trying to understand biomarkers, right? Both for targets and how the disease markers are playing out. And ultimately, how these markers really translate into cognitive or other functional outcomes, right? What exactly is the patient going to get benefited by moving a plasma biomarker from A to B? I think we're still learning that. The third piece of it is around, this is a disease of the brain. And, we don't have in a good way to really see what's going on inside the brain, except depend on secondary markers like EEG, other electrophysiology markers, other markers that you can indirectly read from the periphery or from the cerebral spinal fluid. So those are all challenges that we got to tackle as we work through any program or any target. And lastly, the major challenge is around translation, right? Brain disease is complex. It's not something that we can recapitulate in a dish with, nicely plated cells or neurons. Not even in an animal model where, depression in a mouse is quite different from a depressed human being. So there's a lot of things that we cannot faithfully translate from the preclinical setting to a clinical setting. So as we scale some of the concepts and ideas that looks very nice when you publish a first paper, it takes a lot of effort and work to kind of connect all of these dots. And reproducibility of the findings is an important piece. So it's great to have a paper published, but really reproducing it with the rigor that you need to develop a drug, that takes quite a bit of effort. And then, as I mentioned, those challenges that we have to face as we work through is something that there is no prescription or a roadmap. We've got to figure it out along the way to get to the finish line. But it's exciting, and that is the exciting part of being in health, the brain health, because the rewards are tremendous. If we can cure or if we can treat somebody meaningfully, that's a huge return on the investment that we're making. So it's a great time and a great place to be.
Thank you. And now, Bill, you sit in an amazing place in very large academic institution and creating ventures. So TMC Innovation and Venture Fund is delivering exceptional results. Like the most recent one is Crossbridge Bio, like how fast that happened and how impactful it is. So based upon that success, would love to hear your vision, how you approaching brain science, including in areas which otherwise would remain academic, because they need to scale, and to get scale, they need funding.
Sure. Well, actually, our CEO of Crossbridge, Michael Torres, right there. Wave a hand, Michael. And he is the perfect prototype of how we look at investing. We don't just throw money to the side. But Michael came on as an entrepreneur in residence. And here's what I think is kind of the magic part of it. Michael had been in the industry successfully creating companies. He knew what industry was looking for. And he started those dialogues really early on. Before just spending money, they knew what they were looking for. And so we invested in Michael early to get the technology out of the institution. And he really was very methodical about how he invested that money to really get the data package that they needed. And it was a very tight communication throughout. And it just shows you that if you combine, don't try to take the inventors out of the institute, pair them up with a person like Michael, and it moves so much quicker. As a matter of fact, when we were delighted about the selling for 300 million, but I thought it was a really interesting comment. They said, well, we'd pay you so much more, but you didn't spend that much money. It was like a backhanded compliment to Crossbridge. And we think that's the model. We want to invest in people, connecting them to the technology, and we want to invest earlier than any venture will invest. And we think that there's many more Crossbridges here and from around the world that are coming here. And we're going to continue to push that model.
Yeah, thank you. That is such an amazing structure where we have great framework here for public-private partnership and finding great enablers like Mike and building these programs. So with that, Luisa, as we know, CNS has one of the lowest rates of therapeutic maturation. And if failures happen, these usually are very catastrophic because you design those programs as keeping brain and CNS in mind, so you can't really pivot outside of that. You have looked through a lot of programs, including from academic institutions. When you look at a CNS story and when it is pitched to you, what are the common scaling stories that you find hard to believe? Those that may look great, but until we need to underwrite them.
Yeah, so to your point, it's a lot of people make the correlation with oncology, but I also see the correlation with autoimmunity, which is kind of in the middle in the path. So one of the things that we do a lot, and people are doing in CNS as well, is this idea, well, we'll do a small proof of concept trial in a small disease, and then that will scale up to a larger. And most of the time it does, right? Whether it's a genetic-based disease, but even if it is not genetic-based, this idea that I use a small disease as a proof of concept, and then I scale up to a larger disease, or that I start in a CNS-based disease, and then I go to a peripheral one, or vice versa, it usually does not work that way. So I think that one of the things that people need to really be more, quote unquote, upfront is, okay, this is what we think is going to work on. At the end of the day, you have to follow the science, right? And this is what, in the time and the investment. And because people can see through it. At this moment, the investors, whether it's Big Pharma or whether it's the VCs, they're getting more savvy, right? And so they understand when you're actually trying to position something that has low likelihood of success.
Thank you. That's such a great point. Like building companies keeping in mind the end point, like rather than thinking that these things would organically will grow, right? I mean, even potato don't grow organically. You have to put efforts for that. With that, Julio, we call things breakthrough. The moment these achieve a milestone, for example, preclinical data. However, it may not be the same. Those breakthroughs end up with the patients and benefiting them. Where does this translation specifically breaks for brain science?
Well, it's important that we really define breakthrough here, because it can happen in different ecosystems as far as a therapeutic strategy or a drug is being developed. So if you're referring to a breakthrough that pushes the approach being taken farther along the way through the path forward, that is a breakthrough that will certainly accelerate the presence of the drug or the treatment at the patient level. However, many of the breakthrough may regard more a preclinical studies. And some of the breakthrough actually indicates that there is a better pathway forward, and actually through the breakthrough, you might decide to abandon a certain approach and follow a new one. So that's what I'm saying. Under these circumstances, the breakthrough, even though may end up on the first page of newspapers or whatever, does not result in an immediate benefit to the patient, but actually can open new venues to get there. So,
Yeah, that's a great segue into, now we understand to some extent like what are the things we should think from the perspective of illusions as they are in many times in the CNS space, and then how we scale the programs and the companies that we're building. And one of the examples that we have continued to think and continue to talk about, and is very important, is the oncology model, right? Like we have the great infrastructure here, we have separate, but the companies that are built in oncology are generally different than how we need to think and build in CNS. So, across the street, Houston moves, the MD Anderson moves these oncology programs as a very well-oiled machine. Jim Ray was also highlighting some of their consortia effort on adopting some of the MD Anderson engine on therapeutics creation. So definitely oncology has a speed and agility, but it does, in contrast, CNS has yet to achieve. So with that, Murli, oncology succeeded on very much around target-based approach. However, in brain science, therapeutics development is very messy. So is that in CNS we don't understand or uncouple the biology fully, or we don't have good markers, or we don't have shortcuts as we have in oncology, such as surrogate markers, where you could prove that drug works or doesn't work prior to going on lengthy development?
No, it's a bit of everything. I think you touched on a couple of points. I know Jim Ray is not here, but I think Jim is trying to sort of learn a lot of concepts that have been sort of worked up in the oncology space and seeing how best can we apply it in the case of CNS. But as we all know, there's complexity to brain diseases, frankly, right? It's not, one cell type is defective or it's a particular mutation that's really kind of causing everything. There is a concept of circuit biology, right? So it's a synaptic, it's a circuit that really affects at the end of the day where we think about mental health disease. It's not just a glutamatergic dysfunction, or it could not be a dysfunction right at the level of the hippocampus. The circuit is always involved. So I think the challenge is to really find molecular targets that can modulate the circuit in a meaningful way. And sometimes it's not just one target. You may have to hit multiple approaches at the same time to really have the benefit. It may not be just dopaminergic signaling, it may be this plus something else. It could be hitting the direct pathway and the indirect pathway. So we need to understand the biology fully well. So not only dealing at a cellular level, but also thinking about the circuit level. That's important. The second component is, as we all know, in areas like Alzheimer's, it's not just protein misfolding the issue. It's got to be misfolding errors. It's got to be the clearance mechanisms. It could be neuroimmune as part of that. So just tackling one aspect of the disease may not be moving the needle in the most compelling way, and we may need to think about combination approaches. So that's the other piece of it. And the third one is what I touched at the beginning, right? The whole idea around studying the brain disease, and we don't fully can see everything that's going on, so we are relying on biomarkers, electrophysiological signals, and all of that to make decisions along the way. So I think we have to tie all of these pieces together, and that's really what we'll have to overlay on top of the lessons that we know from oncology. But ultimately, it will come down to identifying the right biomarkers, the biotypes, if you will, because we have sort of named these diseases based on anatomical location, or we have called them based on, some other etiology or symptomatology. But at the end of the day, there is biology, there is pathophysiology and biochemistry. So you've got to tackle them at the pathophysiological level. And I think that's going to be the important piece. I know the previous panel talked about an example in TDP43, which is a pathological protein that is not only relevant to ALS and FTD, but also has got a play in Parkinson's and Alzheimer's. So the more we think about molecular signatures and how we tackle the molecular signatures, and then what right combination works, is going to be the way for how we think about the future. And that's a playbook from oncology, but eventually we need to graduate to the next higher level to bring in circuit biology as part of the equation.
Great. And Bill, as you know, that oncology has great infrastructure in terms of the patient volume and very strong referral framework that allows for them to move the programs very quickly. But something of that doesn't exist yet in neuro. So would love to hear your thoughts, like why is the case and how we can change the paradigm, the way CNS clinics are structured.
Well, I mean, you're talking about 1 trillion connections, synapses of the brain, and the blood-brain barrier serving as the moat to the most complex organ in the body. It's no reason that it's difficult. I think what we are seeing, some interesting technology, for example, out of Rice, Motif is an early investment. And so why we're excited about this was not just cortical stimulation of the brain. If you look at what people do today, and there's been great studies, if someone goes to an office once a week and gets stimulated, the great results really works well. What we're excited about with Motif is it's a device implanted. It is constantly not just pulsing, but it's collecting that data. So it's a really interesting system that can predict relapses. And that's when you start seeing something that's not practical in the real world of a patient having a therapy, to really bringing that all in a captured environment where we're just going to continually learn about the data sets, be able to predict a relapse. I mean, one of the reasons that healthcare don't like pharma around psychotropics is people start feeling well, they stop taking their drugs, and they go through these terrible cycles. But imagine an onboard device where you're just having coffee and you're charging the device, no one knows you have it, and completely remove drugs as a solution. So we're really excited about some of those technologies we see in the med device space. And so we're making those investments. We're going to make a lot of bet on those investments because they have near-term results.
And which is a great reminder, because in CNS therapeutics, we're not only thinking of typical therapies, the devices are also therapy, because many times you are manipulating the neurocircuitry, and that can also result in improving the disease or curing it. With that, Julio, would love to hear your thoughts, how some of these CNS clinics may adopt the way oncology clinics are set up, if they can, and how they should be thinking of translation and gaps.
Yeah, absolutely, because obviously the target is very important, the patient stratification, we've talked about this, the biomarkers. But at the end of the day, also the clinical trial design and endpoints, you need to think about that, right? I mean, the tumor tells you if it's working. The thing shrinks, you kind of know that, right? With neuro, you get a lot of the patient telling whether it is working, and that is not really always quantitative, right? And in some cases, immunology and autoimmunity is in the middle, right? And so what we did to try to solve that is get biomarkers that really correlate with clinical endpoints, meaning, and even as bad as it is, the 6-minute walk, it's still something first that you can measure, and second, that has been established, it correlates with obviously lung function. So I think that's where, CNS and the neuro needs to think about. You may not be as clear-cut as tumors that shrink, and you're like, great, this is working. But it also has to have very quantitative biomarkers that are correlated. And that takes some time, and it's taken autoimmunity 20 years, right? So it's not like you're going to, but you have to think, and to your point, that there is already some addressing. But until you do that, and even imaging is great, and PET is coming, but again, for some diseases, but it's still not super quantitative, right? And so can you, beyond imaging, go to liquid biopsies that are extremely sensitive, because obviously you're not going to have high level of biomarkers in the blood with neural diseases, so something that is extremely sensitive. The other thing we try to do a lot is rely on GWAS data. And I love GWAS data for patient stratification, for target ID, but it doesn't really tell you that it's going to be a therapy. There's been one therapy in the last 30 years that has made it from GWAS to approved clinical, and that's PCSK9. That is it, nothing else. Now, AI is improving, and we're going to get obviously better data, but we have to think about, just because this target, we saw a mutation that correlates with a disease, therefore it's going to be a therapy, right? But it can be quantitative. It can be patient stratification. It can be something to quantitate the clinical trial. So I think we have to think about like that in neuro, because otherwise, again, the clinical trials will be, and we can do the right biology, we can do a lot of those things. But if I always say there's two things that make a drug: is the biology, the science, and then a good clinical trial, right? And so either one or the other is not going to solve it, right?
And again, like Julie, would love your thoughts on if CNS clinics be able to adopt some of the oncology paradigms, if not, like how that would look like, in keeping in mind, like we're working on accelerating the therapeutics maturation. Julie? Yes.
Sorry, can you repeat the last part? I was not. No, I had
Oh,
a
so,
real
so the
bad
question
audio.
is around the oncology clinics, how they are set up, where each patient encounter is opportunity for research. It doesn't exist in CNS. Can some of these CNS clinics adopt, or if not, how their version would look like?
I still didn't get it, the question. I can't hear.
Oh, sorry, you can hear?
Yeah. He cannot hear you.
I'm sorry.
Yeah.
Okay, so the question is, oncology, are you hearing?
I'm here.
I'll tell them. Don't
Okay.
worry about it.
So the question is, the oncology clinics, they are very much set up as research infrastructure. When patients come, that patient also has available all these studies to them. But something of that kind doesn't exist in CNS clinics yet. So how CNS clinics may adopt with their ability to move these programs faster, find the right patients, and match them with the right therapies, like how the oncology clinics are doing.
So you're talking about in promoting and making translational passage more efficient.
Right.
I'm sorry. As I said,
know.
well, I owe an explanation to these people, which is I'm deaf from this year. And so that's why I asked to sit at the very end so I can listen to them. I didn't calculate that there is more voice coming from this. I'm like hearing, boo, boo, boo. I'm sorry, my apologies. But so that
Do you
you
want to
know.
switch the seat? I can come that side.
No, that's okay. That's okay. Well, first of all, there are other systems, such as, for example, Europe, where the transition of new methodology, new technology, new therapeutic approaches move to the clinical arena much faster. But I like to say it's not them that are fast, it's us which are slow in that. And there are so many factors that might affect the proper transition of a therapeutic approach or a drug. And since the vast majority of our drug development is done by big companies and big pharma companies, of course, one factor that entered into the equation is in fact a financial factor. And that has to do with return, and therefore that necessarily makes company quite prudent and cautious. So they need to select the horse battle, and they need to select very carefully. And that slows down usually, for example, by having to obtain more preclinical data to really make sure that they're betting on the right drug. Now, if you want to see another ecosystem, which is actually quite not common, but quite efficient back in Europe, is also the investigator-initiated research trial. Now, in that case, the financial factor might not be the prominent driver, but rather, the science behind it. And but that also carries the fact that the funding of such initiative is very limited. So one way to get around is actually provide a targeted funding for investigator-initiated trial.
And which is a great point, because many times these therapies, there could be only few patients are available. Luisa already highlighted that some of these can't really be translated, going from a small monogenic to more bigger patient population. So this is where academic institution can really drive, even with the IITs and doing end-to-one type of therapies that FDS allows. With that, let's switch to the investment model. So Bill, would love to hear your opinion, given in CNS, the investment is required for long haul. In contrast, in oncology and another immunology, other therapeutic areas, it could be much shorter, even under 18 months. So how at TMC you are thinking of supporting these CNS programs where the investment and infrastructure is needed for a very long period of time?
Yeah, I think it's a great question. I think that we don't really fit the large volume. You know, we're really looking at key areas that we think are really exciting, that are quite differentiated. There's a technology out of Baylor that uses the microbiome to reprogram the brain. And we think this is a really exciting area that could actually reprogram and turn off autism. This is one of the exciting areas. So we would rather go after a technology like that is really, because the large drug players, that's not our space. You know, that's going to be handled by the BMSs of the world and others. And the cost standpoint is really large. So we really look at really differentiated technology. Obviously, I shared with us in med device technology is a place we can play. We're excited about the microbiome. There's a powerhouse of knowledge here on this campus about it. So on the drug side or the CNS side, it's a big game. And we're a shark that's focused on very specific approaches, and we'll let the rest of the world with much larger wallets solve the much larger CNS problems.
Luisa, if you can briefly highlight, what are some of the innovative ways where academic institutions can also mature their programs while they're waiting on outside funding?
So solutions to speed it up, you mean?
To potentially do institution fund to support some of the early science?
Yeah, yeah, I think that there's a couple of things, and we mentioned already there. Neuroindications is not going to be fast readouts. Again, there's ways that we can improve. We talked about the biomarkers. We talked about larger populations of patients that are available, and you can recruit. But again, there are some endpoints that are still going to take some time to get, and there is always so much. I always say that 3 women pregnant for 3 months don't make a baby, right? And so the bottom line is that there are things here that you need some time. And unfortunately, they're not always aligned with the way, as you were mentioning, with the way that VCs and even biopharma, big pharma, think about in terms of long-term, the 2-year turnaround, the 10 years return on investment, and things like that. And so I think it's an area where really support from institutions, from the government. You are seeing, we were talking about these overseas, a lot of that, a lot of strong support from the government, a lot of strong support of patient-centric institutions, nonprofits. That has to be a big driver, and that's why what you guys are doing here is great, but that has to be a big driver, because I don't think that in neuro, not all the indications, obviously, there's always exceptions, but in many of the indications, I don't think that the regular funding it's going to work that well.
Hopefully, that's where this effort would change the model that it is, wherein although some institutions have started using, some of the institutional structuring like Caliber and, Cedars and others, and now we see this big effort here. So I know that we are very close to time, and would love to hear your thoughts, Murli. What are the one big systemic change in your domain that you think would need to happen to allow for industrialization of therapeutics in brain science?
Yeah, I don't think I can narrow it down to one, but one of the one that just comes to mind for me, as we look at the community around us, especially the academic, the medical centers, and all of the facilities we have, in brain health, I think one of the key, there's a lot of progress have been made with biomarkers. I think we are heading in the right direction, right? You got tools, you got better ways to do trials, you got incorporation of digital approaches, and I'm sure we're going to hear about AI and others. So a lot of things are going in the right direction for us, which is all great. But one of the places where the field is struggling today is for targets. We think brain diseases are complex, but there's not a lot going on to really find which are the most compelling targets to pursue. We're still working on muscarinic receptors from the 50, 45 years ago. They're great targets. But in terms of new targets that we need to be uncovering in that space, I think there is a huge effort to be done. And then I think it's for this community to think about how do we quickly de-risk those targets in the diseases we care about. I think there's a significant dearth of targets in the space that we need to be looking for. Alzheimer's, great example. We're working on A beta, tau. Those are two key players. But beyond that, there are other ways we can really go after for various disease types. So, if you look at the community around us in investment, I think our previous panel touched on it. A lot of the investors are ending up investing in the same targets over and over again, or we're trying to reformulate something, we're trying to improve upon something. But really identifying novel targets is going to be the game that we need to really think about hard and fast.
Well,
It's interesting. I always look at what we do here is somewhat of we create a cottage industry of replication. Look at this campus alone. There's 28 IRBs when I arrived here. We actually created a centralized IRB. You know where it falls apart? Everyone wants to be paid this much for their trials, and your university charges this much, and it falls apart. But think about the customer on the other side. You have industries saying, hey, we'd love to do this. I believe, look at Australia as a great model, is they get 50% back of your investment back from the country. Why are people going all the way to Australia? Because they're the population of this state of Texas, geography of the United States. But what have they figured out? It's called island mindset. We're here all by ourselves. We better get a lot smarter about this. And the government leans in. Imagine if we had one first-in-human platform for Texas. I don't even want to try to solve the world, but imagine just in Texas. This place would drive so much business if we could standardize on a couple of things. One centralized IRB for Texas. It's not crazy. And then people could look and say, you got one set of economics, you've got patient flow, and also adding the community hospitals. The fact that we're forcing so much of this on the academic centers, even massive ones like we have here, that involving the community, and they need support, they need financial support to do that. But we could really kind of redesign this on one focused area, first in human, and really transform, I think, this state in this business and make things go so much faster without being redundant and super costly in the process.
and it's such a great point wherein now we have the technologies, including AI, where a lot of these very convoluted processes you can really streamline and have wide variety of institutions working on a very similar format. With that, Luisa, what are your opinion on?
So I agree with a lot of obviously what we're saying. So the one thing I would add is broader and longitudinal patient data sets. So oncology has TCGA, right? And that's huge. And we built a lot of biobanks like the UK Biobank and others in immunology. It cannot be done by a company. It can be, Merck having their own patient data sets, the BMS, obviously we did that. But it has to be really much broader than that. It has to be, again, like the CCJ, so everybody coming together, not only companies, but also governments and access to patients and longitudinal data. That is well annotated. It is critical to any of the things that we talked about. To new targets, again, I don't think GWAS in new targets, but for validation, for patient stratification, for better clinical trials, and for outcomes, as well as PD endpoints. Again, PD endpoint is something that's going to be critical if we ever going to speed up in neuro, right? Target engagement and PD endpoint that is quantified. So having something like that, I think, and I know we talked about MD Anderson and others there, and I'm very happy that they are now focusing on neuro, not just oncology. But that's what they've done very well for onc, right? You come here, you get consent, that after you get patient consent, you do the biomarker, you do the longitudinal, you change, because patients change. In oncology, people don't treat And we were mentioning that they don't treat pancreatic tumors or lung cancer. Now they treat for mutation. So they treat HER2 and EGFR and things like that. And we talked about this, right, that when, for instance, at City of Hope, they looked at patients that had lung cancer and they followed them over 3 to 6 months. After that, they didn't have lung cancer anymore. They just had a completely different biology. I'm sure it's happening here as well. So you have to have that potential to actually not only treat, but then treat and go back and do another biopsy like they do in oncology here, different, and adjust the treatment, not just come and think, okay, I'm going to give you this treatment and this is going to work for the rest of your life. Right?
Which is a great point. You and Murli both highlighting the need of integrated resources such as databases like, oncology also has TCGS and many other databases that allow for, to your point, doing very target-based approaches or the combination thereof. And certainly in the brain science, that is one of the things we also need. Julio, the question is, in your opinion, what are the one change we must make that will help us in industrializing the brain therapeutics?
Amazingly enough, having understood your question, I think, in my opinion, my humble opinion, the major changes that needs to happen, especially in the neurological environment, and more particularly into the chronic disorders of the brain, that right now is extremely expensive for clinical trials, for example. The standard AD trial has to be 18 months or longer in order to see any meaningful event. And so, and I believe that AI will be critical to allow us to really speed up these times through the creation, for example, of appropriate virtual patient cohorts that will allow rapid screening and pre-selection of candidate drugs that have a higher chance of proving to be. And with that, we need to develop even better marker that can help us monitor how the trial is progressing. We can't afford to wait 18 months, 24 months to have an answer. But most important, even investor cannot wait 18 months to have it. So it's like, in my opinion, a combination between AI as we progress and more biomarkers that allow us to determine the effectiveness of a drug. And I hope those changes are upcoming.
No, great discussion. I think the topics we touched upon certainly very much were this effort with DEPRET and UTMB, TMC, and the partners are focusing on. So we're very excited for the next 5-10 years of what's going to happen in this Houston ecosystem. And I know we had a lot more questions to chat, but we had the limitation of the time. So, and we when you get really, enthusiastic and amazing people like this group, you need a day to talk about these topics. So with that, I want to thank all the panelists and everybody, all of you here. And let's give a round of applause for the organizers. As I said, that they have been amazing with this event. And with that, we'll take some maybe pause for food and things, and we'll come back for the next session. Thank you.